Hello, my name is Astrid Macharé and I'm going to talk about Caplacizumab for acquired thrombotic thrombocytopenia purpura. As a definition, we have that acquired thrombotic thrombocytopenia purpura (TTP) is a potentially life-threatening thrombotic microangiopathy resulting from systemic microvascular thrombosis and leading to profound thrombocytopenia, hemolytic anemia, and organ failure of varying severity. What causes it? Acquired TTP is caused by a severe deficiency of ADAMTS13, a disintegrating metalloproteinase with a thrombospondin type 1 motif member 13, due to the presence of inhibitory autoantibodies. Decreased ADAMTS13 activity leads to an accumulation of ultra-large von Willebrand factor multimers, which bind to platelets and induce aggregation. These microthrombi cause tissue ischemia and organ dysfunction, resulting in early death or in long-term complications such as cognitive deficits, depression, and arterial hypertension and a shortened life expectancy.
Acquired thrombotic thrombocytopenic purpura, or ATTP, is a rare, life-threatening autoimmune blood clotting disorder. During the normal blood clotting process, the plasma protein von Willebrand factor is important in recruiting blood clotting cells, also called platelets, to damaged vessels to seal the injury and stop the bleeding. In healthy individuals, von Willebrand factor is immediately cut up into smaller pieces by an enzyme called ADAMTS13 to prevent spontaneous recruitment of platelets when blood vessels are not damaged. However, in ATTP patients, antibodies that block ADAMTS13 from working properly are present. This results in an accumulation of ultra-large von Willebrand factor molecules which will bind to blood platelets and cause excessive formation of blood clots. The formation of these blood clots in small blood vessels throughout the body leads to a severe reduction in platelets, also called thrombocytopenia, a further breakdown of red blood cells referred to as hemolytic anemia, and an insufficient blood supply to tissue, also known as tissue ischemia. This results in organ dysfunction, commonly involving the brain, heart, and kidneys, and may cause acute thromboembolic events such as stroke and heart attack. Despite the current standard of care, ATTP patients remain at risk for significant morbidity and mortality.
Now we have the Caplacizumab, that is a humanized bivalent nanoantibody consisting of two identical humanized subunits, genetically linked by three alanines, which acts on the von Willebrand factor A1 domain and inhibits the interaction between von Willebrand factor and platelets.
Okay, dear students, today I am with a new drug update, and the drug name is Caplacizumab. So Caplacizumab is a new drug approved in 2019. Now you remember by the terminology itself, MAB means monoclonal antibody, Zumab means it is humanized, CI means the indication of this MAB will be any disease related to circulation. Now you have to understand that you need to understand a terminology called acquired thrombotic thrombocytopenic purpura. So this is a very rare disorder, and in this disorder the main pathogenesis is von Willebrand factor is activated, and this will combine with platelet to form thrombosis that will lead to ischemia across many parts of the body. Along with that, most of the platelets are consumed for thrombosis, so that will lead to thrombocytopenia, hence the name thrombotic thrombocytopenic purpura. Now the drug was developed in view of attacking this von Willebrand factor, which is a triggering factor. So this MAB, that is Caplacizumab, is a nanobody which will attack this von Willebrand factor, and it will not allow the factor to bind with platelets, so there is no thrombosis, ischemia, or thrombocytopenia. So that is the new drug that is approved in 2019. Thank you.
Acquired thrombotic thrombocytopenic purpura is a potentially life-threatening condition caused by an autoantibody to ADAMTS13. Reduced activity of ADAMTS13 leads to the accumulation of ultra-large von Willebrand factor molecules that can bind to platelets and induce aggregation, leading to systemic microvascular thrombosis. This in turn can cause severe thrombocytopenia, hemolytic anemia, and multi-organ failure. Caplacizumab is a nanobody, a single monomeric variable antibody domain that targets von Willebrand factor and blocks interactions with the GP1b receptors on platelets. Investigators conducted a Phase 2 single-blind study at 56 sites worldwide, randomizing 75 patients with acquired thrombotic thrombocytopenic purpura to receive either caplacizumab or placebo, in addition to standard of care treatment, daily plasma exchange, and immunosuppressive therapy. As compared with standard treatment plus placebo, standard treatment plus caplacizumab reduced the median time to recovery of platelet counts. Exacerbation of thrombocytopenia within 30 days after the end of daily plasma exchange was also less frequent with caplacizumab, but bleeding-related adverse events were more frequent in the caplacizumab group. Thus, caplacizumab induced a significantly faster resolution of acute acquired thrombotic thrombocytopenic purpura than did placebo. Full study results are available at nejm.org.
Application in medicine. Caplacizumab is indicated for acquired thrombotic thrombocytopenia purpura in combination with plasma exchange and immunosuppressive therapy.
Acquired thrombotic thrombocytopenic purpura, or TTP, is an immune-mediated disorder caused by deficiency of ADAMTS13. ADAMTS13 processes large von Willebrand factor molecules into smaller functional units. Lack of ADAMTS13 leads to unrestrained von Willebrand factor platelet adhesion, causing microthrombosis, thrombocytopenia, and hemolytic anemia. Caplacizumab is a humanized bivalent variable domain-only immunoglobulin fragment that inhibits von Willebrand factor platelet interaction and has been effective at reversing the thrombosis and hemolysis and correcting thrombocytopenia in Phase 2 human studies. In this multicenter randomized placebo-controlled trial, 145 patients with a diagnosis of TTP based on clinical presentation who had had one previous plasma exchange treatment were randomized to 10 milligrams of caplacizumab daily or placebo, in addition to daily plasma exchange and glucocorticoids. The primary endpoint was the time to platelet count normalization. Patients who received caplacizumab achieved faster platelet count normalization than those who received placebo. At any given time, caplacizumab-treated patients were 1.55 times as likely to have a normal platelet count. The composite secondary outcome of TTP-related death, TTP recurrence, or major thromboembolic event occurred in significantly fewer patients who received caplacizumab. A greater proportion of patients who received caplacizumab had bleeding-related adverse effects, most of which resolved without intervention. The authors conclude that caplacizumab reduced the time to platelet count normalization and the incidence of a composite of TTP-related death, TTP recurrence, or major thromboembolic events. Full trial results are available at nejm.org.
Now we have pros and cons. As a pro, we have the caplacizumab plus plasma exchange is associated with faster normalization of platelet counts and a lower incidence of a TDP-related death and recurrence. And as a con, we have bleeding-related adverse events, mainly mucocutaneous, were more common in patients taking caplacizumab compared to those on plasma exchange plus the placebo. It was a 65% versus a 48%. The rate of serious adverse events of bleeding was 11% for Caplacizumab versus 1% for placebo. Issue apply in Ecuador. At the moment in Ecuador, there are no confirmed cases of the acquired TDP, and there are no studies that can affirm the existence of cases in this country. As a conclusion, we have the caplacizumab induced a faster resolution of the acute TDP episode than the placebo. The platelet protective effect of caplacizumab was maintained during the treatment period, and caplacizumab was associated with an increased tendency toward bleeding as compared with placebo.
What we achieved actually was the number of the days for the normalization of the platelet was significantly lower for those patients that they were treated with caplacizumab. And as a secondary outcome was extremely interesting that because we could see that for 30 days that patients were treated with caplacizumab, they were protected to have exacerbation.
And finally, we have the preferences. Thank you so much for watching. I hope you like it and find it informative.